We must gain an understanding of the patient's strengths and weaknesses. We must gain the confidence, respect, and cooperation of the patient. And armed with this information, we can then help the patient understand and begin to come to terms with the condition. We can select, plan, and coordinate investigation and treatment, and we can communicate with the patient and others about the illness, its ramifications, and management. As we all know, the defining physician-patient relationship, which is the sine qua non of our endeavors, is not explicitly encouraged, nor is it reimbursed. Bringing this to the attention of our payers is our ineluctable responsibility and has to be our mission. During the 17 years we have used E&M coding, which I find no more likely to ensure appropriate quality and compensation, I have not spoken to a single physician who believes that they contribute to clinical quality. Our disbelieving use and teaching of these codes must send the wrong message to our medical students and residents of our belief in ourselves. And our re-entry to the debate to improve the value of E&M based simply on what is humanly right would reverberate throughout our ranks. Reimbursement is based on E&M and is considered by many to have created some perverse incentives to doctoring. Let me explain. The American Medical Association appointed the Relative Value Reimbursed Update Commission, called the RUC, to evaluate and recommend E&M code reimbursement to the government agency, the Center for Medicare and Medicaid Services, or CMS, to enable the government to define how our allotted funds, otherwise known as the Medicare Medical Sustainable Growth Rate, or SGR, are dispersed among medical fields. Since its inception, proceduralists have occupied the majority of seats on the RUC, and as you may expect, its decisions have favored procedures contributing to the altered face and cost of American medicine. Over the past 5 years, for example, laboratory tests increased 530%, MRIs 94%, while office visits of established patients increased only 12%. Not surprisingly, during this time, entry into primary care has fallen significantly, and our patients complain that doctors do not listen or talk to them and only seem to want to order tests. This is unfortunately precisely the change in doctoring one would anticipate given the incentives created by the RUC recommended decisions by the CMS. In ethical terms, a moral community binds its members together and is constituted by the collective will of individuals espousing a set of commonly held moral commitments, other than self-interest. We physicians constitute just such a moral community, and some of the RUC work product appears to me to be discordant with these principles. While physician face-to-face time is threatened, the complexity of our evolving science cries for its expansion, and the crowding of our workplace escalates. It is increasingly inhabited by technologic advances which pose deceptively as healthcare, while in reality they are only the tools of doctoring. It is flooded by our accumulating obligations such as evaluation and management coding, complicated by current renditions of the electronic health record and pay-for-performance documentation, e-prescribing, and the need to satisfy the demands of insurers, more often defined by economics alone, yet masquerading as quality. We acknowledge the value offered by others, such as evidence-based medicine data and possibly maintenance of certification requirements. Our future, as we all are coming to understand, includes comparative effectiveness studies, and while we accept their potential value, we cannot but view with trepidation the role physicians will be called upon to play as quality of life year cost analyses are applied to them. Each of these concepts has evolved alone, yet none exist in isolation. Collectively, they carve out our accumulating quantities of our patient-focused time. Humanistic medical care requires the combination of a cognitive component for diagnosis and management and an affective component which experience and the context of the patient's life, personality, and illness variables are considered. David Leach, the former executive director of the ACGME, stated that context-based physician behavior demands the application of practical wisdom and prudence, and the need at times to break rules to accommodate life's realities, and I use this beyond the evidence-based medicine context he intended. Humanism is lacking ethically and practically if either aspect of care is ignored. These requirements risk converting some, or perhaps in time to come, most of the patient-physician interaction to a cookbook process, yet they cannot quite so simply manage doctoring's fusion of humanity, diagnostic uncertainty, and scientific probability, to borrow from Osler. In short, we have developed and are applying methods of care before studying their intended and unintended consequences, and we have not commented fully on the risks in their application. We need to ask, by conforming, are we hastening the death of our guild? And if so, what can we do differently? Our ethos needs tending now as much or more so than it did in the past, when we in medicine, like no other enterprise in a capitalistic democracy which hopes to survive, have been asked, and we have consented, to encourage production of a mission-centered and suboptimal product. We have done so to satisfy our country's economic planning, despite the fact that these same economists ignore the cost side of our equation, as we physicians, accounting for less than 20% of the healthcare dollar, are called upon to squander more than half of our earnings on administrative costs, more than double the level spent in other countries. But application of our ethos will not be easy. Our history reveals that we have often stumbled in its use. For example, a century before Hippocrates, Hammurabi's medical code, and he lived from 1795 through 1750 BC, defined differing payment and punishment for doctors caring for the wealthy and caring for the poor. To name only a few recent examples, the ethos of doctoring yielded in the 1900s in Germany during National Socialism, and certainly during my life in South Africa under apartheid. I propose we begin by convening a summit of physician stakeholders and thought leaders within and beyond the United States to develop and define an understanding of the ethos of the physician, based in part on contentment theory and culminating in a charter on professional flourishing as a parallel document to the physician's charter on professionalism. Though the ethos of doctoring is universal, crossing all times and cultural divides, its application is not, changing from country to country and from time to time, dependent upon local circumstances. Two documents are therefore necessary. First, we must define our ethos. Our ethos is not an abstraction, but a set of behavioral principles which determine how we respond to the sick. It is our character, our behavioral characteristics, our internal motivators, our physician-patient relationship requirements, the ethics of our professionalism, and our guardianship of appropriate autonomy for ourselves and our patients. Our ethos has not been, nor will it be forever impenetrable, and therefore our definition must incorporate integrity to counter human weaknesses such as envy, greed, and power, and preeminently, our definition must include personal responsibility, because if we do not accept responsibility, in the end we will surrender our responsibility to others. Second, we must identify the dynamics necessary for the application of our ethos specific to each society and country. The physician workplace should be built to encourage those values possible locally for physician and patient flourishing while discouraging distractions. For example, we may consider the misconceived incentives, defensiveness, and irrelevancies in our workplace, while for others, workforce issues may dominate. Once fully characterized, teaching of the philosophical backdrop to doctoring should be defined. Our pre-medical and medical school requirements should include medical and behavioral ethics courses to capture and foster the spirit of altruism in young students. We must explore its clinical value and develop methods of assessing how students and physicians integrate this behavior, and we must monitor its use in the political forum.